Is it hyperkalemia management? Sorry. And glucose is high. Sodium is in the borderline, like 135 is not that low. Creatinine is higher. Maybe he has CKD, that's why creatinine is higher. Hypocalcemia goes with the CKD, but why hyperkalemia? Glucose, he is diabetes. Or we can look for the drugs. Okay, what changed? CKD is very abnormal thing. Okay. In the outpatient setting, hyperkalemia in our outpatient setting, hyperkalemia is often reduced. Hyperkalemia is most often caused by reduced urinary potassium excretion due to renal insufficiency or medications or disorder that impair the RAS, renin angiotensin axis. Less common causes include the move. Less common causes include the movement of potassium from the intracellular to extracellular space, uncontrolled hyperglycemia, metabolic acidosis, or increased tissue catabolism, trauma, tumor lysis syndrome. Hyperkalemia is usually asymptomatic until potassium rises. Hypercalcemia is usually asymptomatic until potassium rises to more than 6.5 milliequivalent, but acute acute hyperkalemia can sometimes cause symptoms at lower level. Common manifestations include ascending muscle weakness with flaccid paralysis, ascending muscle weakness with flaccid paralysis, cardiac arrhythmia, heart block, bradycardia, ECG changes, Tolpictic wave, short acute interval, QRS widening sine wave, urgent therapy, calcium gluconate, insulin with glucose is typically reserved for ECG changes. Potassium more than 6.5 milliequivalent or rapidly rising. Potassium due to tissue breakdown, none of which are present in this patient. The next step is to exclude the secondary causes, uncontrolled hyperglycemia and tumor lysis syndrome. A review of the recurrent or current medication should be conducted to determine whether any trigger hyperkalemia. Common offending agents include non-selective beta blocker, potassium sparing diuretics, AC inhibitor, ARB, non-steroidal anti-inflammatory drugs. The patient with CKD and a significant cardiac history is likely on a renin-angiotensin-aldosterone system inhibitor, which often triggers hyperkalemia. Okay, yes, in this box, everything is mechanism. Okay, ACE inhibitor and ARV decrease aldosterone secretion, decrease angiotensin 2 production, block angiotensin 2 receptor. NSAID decrease renin secretion, decrease aldo, decrease renal perfusion, decrease distal sodium delivery, and decrease ENaC activity. Potassium sparing diuretics actually inhibit ENaC, amiloride, and aldosterone receptor, spironolactone. So spironolactone, aldosterone receptor, and inhibiting ENaC is amiloride. Heparin decrease aldo production. Trimethoprim inhibits ENaC. Cyclosporin blocks aldosterone activity. Non-sedative beta blockers interferes with beta mediated intracellular potassium intake. Digoxin inhibits sodium potassium ATPase, and succinylcholine sucsa causes extracellular leakage of potassium through acetylcholinesterase receptor. Okay, hello, hello, can you hear me? Hello, I can hear you. Is there any skin finding? Okay, this patient has developed non-specific symptom. This patient has developed non-specific symptom like nausea, malaise, dizziness, 2 weeks after undergoing resection of the prolactinoma. After undergoing resection of the prolactinoma can be complicated. Okay, can be complicated. Uh, can sorry, prolactinoma. The post-operative period of pituitary surgery can be complicated by disrupted salt and water balance from either one or both of the following: arginine vasopressin deficiency, AV, arginine vasopressin deficiency, formerly known as central diabetes insipidus, characterized by polyuria due to water diuresis with normal to slightly elevated serum sodium. The deficiency results from dysfunction of the AVP producing neuron from the pituitary stalk manipulation and occurs during the first few days after the procedure, usually resolving within a week. Syndrome of inappropriate antidiuretic hormone low or caused by normal or low urine output due to renal water retention with hyponatremia. SIADH is the result of uncontrolled release of preformed AVP from degenerating neurons and arises several days after the procedure, lasting up to a few weeks. Post-operative management includes measurement of serum electrolyte for the first few days after the procedure to evaluate for both AVP and SIADH, and for several weeks afterward to evaluate SIADH. Immediate post-operative evaluation for secondary adrenal insufficiency, which can cause non-specific symptoms and characterized by low ACTH, and is also recommended. These patient has several normal morning cortisol, including prior the visit, making adrenal insufficiency unlikely. She is also outside the window for post-surgical adrenal AI. Therefore, adrenal evaluation is not needed. Okay, what's the window for adrenal AI? If there is adrenal adenoma, like uh, in adrenal adenoma, we can do, I don't know, we can do the CT scan, CT scan of the abdomen, like CT scan of the abdomen with adrenal protocol. There is something like that. So they asked us about the. Can you tell me your question again? Okay, window for adrenal protocol. This actually means the timing of the stress, like surgery, illness, hypotension, when adrenal support is necessary, and the criteria used to decide when to start hydrocortisone or other glucocorticoid. Like the window for adrenal protocol. Wait, the window for adrenal protocol. This means the timing of the stress, like a window for adrenal protocol means you need adrenal support. This is the window, like you done the surgery, there may be stress, there may be adrenal insufficiency after, because stress or surgery or any sort of hypotension can cause adrenal insufficiency, so you need corticosteroid or hydrocortisone or glucocorticoid. You need that or not. If you need that, that means like from surgery up to healing, this means the adrenal This means the window for adrenal protocol, as far I think. You got it? May not be. Like if you do any adrenal surgery, like if there is any adrenal adenoma, you resect the adrenal gland. What will happen? Your brain can anytime uh, got stressed, and you need the hydrocortisone at that particular moment, like adrenal gland producing steroid. So, and steroid is a life what can I what can we say, life saving hormone. So you need steroid on that time. So that was the window from resection to healing. That is the period. Maybe like if someone is outside the window, what does it mean? It means they are not acutely ill or stressed enough to warrant stress dose steroid. That means if you just cross the stress period from surgery to up to healing, that was the window. Wait, why are you picking pheochromocytoma? Wait, pheochromocytoma is episodic hypertension, and this episodic headache, hypertension. 3-year-old patient, you will not gonna found the headache. And pheochromocytoma is tumor of the adrenal gland, isn't it? Adrenal, yes, adrenal gland is top of the kidney, but they actually specified that superior pole of the right kidney. So it is in the kidney, not in the adrenal gland. If you think about the adrenal gland, their neuroblastoma happens in the adrenal gland too. Then it is a tumor. It's a tumor of the child. Yes. Okay. Okay. Look at the neuroblastoma first. Neuroblastoma can come with the malignant abdominal mass in children. However, the mass arises in the neural crest cell, like adrenal gland, not the kidney, as in this patient. In addition, it typically presents in children age less than 2. Okay, and other like, okay, now I am reading the explanation. Wilms tumor is a renal cancer arising from the metanephrons and is one of the most common cause of malignant abdominal masses in young children. The tumor typically occurs sporadically but can be associated with certain symptoms: Weger syndrome, Wilms tumor, aniridia, genitourinary abnormality, range of the developmental delay, Beckwith vitamin. The typical presentation involves child age 2 to 5 with an unilateral abdominal mass that do not cross the midline. The mass is asymptomatic. However, some patients may have associated abdominal pain or hematuria. Hypertension can occur as in these children due to renin secretion by the tumor cells or compression of the renal vasculature by the mass. Abdominal ultrasonography is the first step. Abdominal ultrasonography is the first step in the evaluation of the abdominal mass. Subsequent abdominal CT scan or MRI can further characterize the extent of the tumor pathology during surgical excision or biopsy is diagnostic. Okay. Urine osmolality is more than 600. Yes, maybe D. So look at the box first. Very hard to remember. Okay, there are plenty of box. Okay, and renal also hates us. Okay, Evolution of polyuria. Urine output more than 3 liter per day, and a urine output more than 3 liter per day, and measure urine osmolarity. Measure urine osmolarity. If urine osmolarity less than 300, then water diuresis. AVP disorder, primary polydipsia. If urine osmolarity is less than 300 milliosmol, water diuresis, AVP disorder, and primary polydipsia. If urine osmolarity is 300 to 600 milliosmol per kg, water and solute diuresis, further testing. If it is more than 600 milliosmol per kg, solid diuresis, glucose, urea, and mannitol. This critically ill patient has developed polyuria, urine output more than 3 liter per day following a craniotomy. Urine output more than 3 liter per day following a craniotomy. Polyuria can be classified as water diuresis. Water diuresis due to urinary loss of solute-free water, either from primary polydipsia or from arginine vasopressin resistance or deficiency. Solid diuresis. Solid diuresis due to urinary excretion of solid diuresis due to urinary excretion of an osmolarity active substance, glucose or mannitol, that draws water into the urine. Water and solute diuresis can be differentiated by measuring urine osmolarity. Low urine osmolarity less than 300 milliosmol per kg indicates water diuresis. Dilate urine. High urine osmolarity more than 600 milliosmol per kg, as in this patient with solute diuresis. Concentrated urine. Equivocal urine osmolarity 300 to 600 milliosmol per kg warrants further evaluation. Solid diuresis is usually caused by urinary excretion of non-electrolyte substance, glucose, mannitol, urea, although diuresis from electrolyte loss can occur. Sodium loss after large volume saline administration. Okay. These patients' hyperglycemia, glucose more than 348, has led to osmotic pulling of water out of the cell. Hyponatremia into the urine, polyuria and glycosuria. Hyperglycemia induced osmotic diuresis can cause variable serum osmolarity and sodium. In this patient, combination of hyperglycemia increases osmolarity and hyponatremia decreases osmolarity explain his normal serum osmolarity. In patients with brain injury trauma procedure who develop polyuria and hyponatremia, cerebral salt wasting syndrome, urinary sodium losses due to brain natriuretic peptide secretion should be considered. However, cerebral salt wasting syndrome is characterized by low serum osmolarity, prominent hypovolemia, unlike in this patient. Okay. Yes. Syndrome of inappropriate antidiuretic hormone secretion also causes hyponatremia with high urine osmolarity, but polyuria is a feature. High urine osmolarity due to urinary solute becoming more concentrated as water is pulled out of the urine by antidiuretic hormone. No polyuria. In contrast, high urine osmolarity in solutes in solute diuresis is due to high solute concentration pulling water into the urine. Polyuria. Okay. Yes. In children, MCD is the diagnosis. If steroid does not actually controls the nephrotic syndrome, then we can do biopsy for looking other pathophysiology. Okay. Yes. Yes. This patient has acute onset edema, hypoalbuminemia, hyperlipidemia, proteinuria, finding consistent with nephrotic syndrome. In this case, patient most likely has minimal change disease, which is most common cause of nephrotic syndrome, which is most common cause of nephrotic syndrome in a young children, which can occur spontaneously or be triggered by infection. Nephrotic syndrome results in urinary loss of proteinuria, including albumin, hypoalbuminemia. This leads to uh, decreased capillary oncotic pressure with resultant shift of fluid from the vasculature of the interstitial space, causing edema. Periorbital peritibial hyperlipidemia is common and appears to be increased hepatic lipoprotein production in response to low oncotic pressure. Blood pressure and creatinine can be blood pressure and creatinine are usually normal. Because nephrotic syndrome due to MCD, minimal change disease, is caused by T cell dysregulation and cytokine mediated podocyte injury, leading to increased glomerular permeability. Management is empiric immunosuppressive therapy with corticosteroid. Minimal change is highly steroid sensitive. Minimal change disease is highly steroid sensitive. More than 90% of the children achieve remission. However, relapse is common, typically requires repeat corticosteroid course. Yes, ACE inhibitor are used in certain nephrotic syndrome. Although albumin can transiently increase oncotic pressure in nephrotic syndrome, this therapy is not recommended for patient with localized this therapy is not recommended for patient with localized edema due to complication of the vascular volume overload hypertension. Albumin with diuretic therapy can be considered in massive edema, anasarca, pleural effusion, which is not seen in this patient. So albumin and diuretic therapy can be considered in massive edema, anasarca, pleural effusion, which is not. A and E. Diagnosis of MCD in a young child is usually clinical, does not require biopsy, imaging, kidney ultrasound. In the setting of clinical finding, biopsy is indicated in adults with nephrotic syndrome due to increased likelihood of the etiology other than other than MCD, focal segmental glomerulosclerosis. In contrast, biopsy for young children with nephrotic syndrome is reserved for atypical cases, hypertension, hematuria, elevated creatinine, or steroid resistance disease, finding not seen in this patient. Okay. Where is the stone? Temperature is normal too. So this patient has acute renal vein thrombosis (RVT). Renal vein thrombosis is markedly increased glomerular pressure, leading to renovascular congestion. Renovascular congestion, capsular stretch, manifesting as flank pain and hematuria. Renal vein thrombosis most likely occur in the setting of nephrotic syndrome due to urinary loss of anticoagulant proteins and alteration of hemostatic balance, but can also occur with acquired hypercoagulability associated with malignancy as seen in this patient or trauma. Lab analysis typically demonstrates hematuria with an otherwise bland urinalysis and elevated lactate dehydrogenase level, possibly related to necrosis in the setting of thrombosis. AKI may occur but is more typical in the setting of bilateral RVDs. Renal ultrasound with Doppler and abdominal CT scan has low sensitivity and may demonstrate only an enlarged kidney, although a Doppler ultrasound may show a reversal of diastolic flow. The diagnosis is confirmed by CT or MR angiography or renal venography. CT, MR angiography or renal venography. Management depends on the presence of the AKI, which if present, requires urgent clot removal, thrombolysis, thrombectomy, otherwise anticoagulation alone is appropriate. In patient, nephrolithiasis can cause flank pain, hematuria, however, it would not explain the enlarged kidney with hydronephrosis. The pain of nephrolithiasis is often paroxysmal rather than dull and constant pain. And there is significant overlap in the presentation of renal infarction and acute RVT. However, renal infarction most commonly occurs due to cardioembolic disease like atrial fibrillation resulting in incomplete infarction and a waist-shaped area, incomplete infarction and a waist-shaped area of ischemia. mm, on imaging. In addition, patients frequently report abdominal pain in addition to flank pain. Acute increase in blood pressure due to renin release is common. Okay. Okay, it's management of severe hypercalcemia. This patient has severe symptomatic hypercalcemia in the light of smoking history. In the light of smoking history and associated lung mass, this is likely represent humoral hypercalcemia of the malignancy due to secretion of the parathyroid hormone related protein. Severe hypercalcemia, calcium more than 14 milligram per deciliter, especially with a rapid rise in serum calcium, cause cause weakness, gastrointestinal distress, and neuropsychiatric symptoms, confusion, stupor, and coma. Patients are typically volume depleted, as suggested by patient's blood urea nitrogen to creatinine more than 20 due to both polyuria from hypercalcemia induced nephrogenic diabetes insipidus and decreased oral intake. Patients with severe hypercalcemia require aggressive saline hydration, severe several liters of normal saline to restore the several liters of normal saline to restore the intravascular volume and promote urinary calcium excretion. Calcitonin by inhibiting the osteoblast mediated bone resorption quickly reduces serum calcium concentration, may be administered concurrently with saline. Bisphosphonate, pamidronate, zoledronic acid also inhibit bone resorption and provide sustained reduction in calcium level. However, the calcium lowering effect of bisphosphonate is delayed, usually occurring 2 to 4 days. They are typically given after initial administration of the saline and calcitonin. Okay, now box. Management of hypercalcemia, short-term normal saline hydration plus calcitonin. Management of hypercalcemia, if it is severe, calcium 14 milligram per deciliter or symptomatic, normal saline hydration plus calcitonin. Avoid loop diuretics unless a volume overload, heart failure exists, and long-term management. Bisphosphonate. Bisphosphonate should be given 2 to 4 days after. Bisphosphonate is delayed usually. Okay, no. Bisphosphonate start working 2 to 4 days after. Okay. For long-term treatment, bisphosphonate. Okay, moderate calcium 12 to 14 milligram per deciliter. Usually, no immediate treatment required unless symptomatic. Treatment is similar to that severe hypercalcemia. Asymptomatic or mild calcium less than 12, no immediate treatment required. Avoid thiazide diuretics, lithium, volume depletion, and prolonged bed rest. Okay. Okay. Patient patient smoking history, subacute voiding symptom, dysuria, urgency frequency, suprapubic pain, and hematuria likely indicate bladder cancer. Most cases arise in adults more than 40 and have a chronic exposure to chemical carcinogens such as cigarette smoke or industrial chemicals. Common manifestations include hematuria, voiding symptoms, suprapubic pain. Hematuria tumors are fed by new friable blood vessels. Tumors are fed by new friable blood vessels that often bleed into the urinary tract. Hematuria tends to occur throughout the maturation and may be a gross, visible, or microscopic. Voiding symptoms, tumors often protrude into the bladder and reduce bladder volume and can cause detrusor overactivity leading to subacute or chronic voiding symptoms such as dysuria, frequency, and urgency. Although bladder cancer is often associated with painless hematuria, no pain during maturation, some patients with bladder cancer have dysuria as part of their voiding symptoms. Suprapubic pain. This patient indicates more advanced tumor that has penetrated the muscle and invaded the surrounding soft tissue and nerves. Urinalysis is generally the first test to choice to confirm hematuria. More than 3 RBCs of high powerful to rule out other common causes of hematuria such as infection, significant pyuria, bacteriuria, leukocytosis, glomerulonephritis, red blood cell cast, dysmorphic red cell, cystoscopy with biopsy, and urinary tract imaging CT urogram then required if no clear cause is evident. Okay, yes, bladder cancer, more than 90% of the urothelial carcinoma, increased risk with smokers and exposure to industrial carcinogens. Manifestation: painless hematuria throughout maturation, irritative voiding symptoms, frequency, urgency, dysuria, regional pain. Diagnosis: flexible cystoscopy with biopsy gold standard, and urine cytology. Staging: transurethral resection of bladder tumor and upper urinary tract imaging, IVP, MRI, CT scan. Treatment: no muscle invasion, transurethral resection of the bladder tumor, and intravesical immunotherapy. Muscle invasion, radical cystectomy, and systemic chemotherapy. Metastatic systemic chemotherapy and immunotherapy. Okay. Why there is bruise? So how this bruise? mm, is it renal artery stenosis? No, it's static nephropathy. If we think in simplified way, then it be easier. Okay. This patient's age, nocturia dribbling. This patient's age, nocturia, dribbling, weak urinary stream initially suggests a BPH. However, lab evaluation show proteinuria and elevated creatinine which are unexpected with BPH alone, given his long-standing diabetes. These findings, the given his long-standing diabetes, these findings make diabetic kidney disease the most likely cause. Diabetic kidney disease is a microvascular process, microangiopathy, that predominantly affects glomeruli. It is commonly asymptomatic, but it is commonly asymptomatic in early stage, but found on routine studies. These patients' risk factor include long-standing diabetes mellitus more than 5 to 10 years, evidence of another microvascular disease, retinopathy suggested by decreased visual activity, poor glycemic in control, A1C more than 7, um, A1C more than 7, higher level recommended only for patients who are elderly and have increased risk for hypoglycemia, poorly controlled hypertension. 130/80 proteinuria, particularly if persistent, is an important clue for diagnosis, although a positive urine dipstick test revealed these patients' proteinuria. The preferred screening test is the random urine albumin creatinine ratio, which detects excess albuminuria earlier. Proteinuria is associated with increased risk for cardiovascular mortality, concurrent cardiovascular disease, like that in this patient cardiac blue myocardial infarction. Okay, neurogenic bladder can cause urinary symptoms, but typically results from spinal cord injury or multiple sclerosis. It's often accompanied by bladder spasm and would not cause elevated creatinine or proteinuria. Diabetic autonomic neuropathy can affect the bladder but causes overflow incontinence, continuous dribbling with high post-viral residuals. These would not explain proteinuria or elevated creatinine. D, C, and E. BPH. BPH explains this patient's urinary symptoms and increases the risk for obstructive uropathy, urinary outflow obstruction, urinary outflow tract obstruction. But post-viral residual less than 50 ml is inconsistent with significant obstruction. In addition, BPH is not associated with proteinuria and does not cause elevated creatinine unless complete obstruction occurs. Okay. Yes, it's treatable. Okay. In natural history of diabetic nephropathy, there is uh, hyperfiltration, there is incipient diabetic nephropathy, and there is overt diabetic nephropathy. So hyperfiltration means glomerular hypertrophy and increased GFR. In incipient diabetic nephropathy is mesangial expansion, glomerular membrane thickening, arteriolar hyalinosis, moderate increased albuminuria, and hypertension. And overt diabetic nephropathy, there is Kimelson-Wilson lesions, tuberous fibrosis, overt proteinuria, nephrotic syndrome, and decreased GFR. Initially, GFR is high, then later on, GFR is low. Sorry. Yes. Nocturnal aneurysms or nighttime urinary incontinence age more than 5 is common children condition, particularly in boys. In an otherwise asymptomatic child, urinary aneurysms is typically genetic, mostly have mostly have a parents affected during childhood development with self-resolution expected as bladder control matures. However, an underlying medical condition should be suspected when other signs and symptoms are present, as in these cases. In addition to wetting the bed, this condition is irritable and inattentive with tonsillar hypertrophy. These findings concerning for obstructive sleep apnea, the underlying cause of his aneurysis may reflect apnea, effects on arousal response, effects on bladder pressure, urinary hormone secretion, or difficulties awakening in response to full bladder instead of daytime somnolence seen in this adult with OSA. Behavioral counsel, inattention, impulsivity, and mood changes, emotional lability are common manifestation of sleep disturbance in children. OSA is also associated with increased blood pressure, as in seen this patient. Chronic symptoms can result in poor growth, decreased nocturnal growth, decreased nocturnal growth hormone secretion, and cardiovascular complication, core pulmonary. Evaluation of OSA is nocturnal polysomnography sleep study, which detects and quantifies respiratory pauses, desaturates during sleep, and treatment of OSA added to tonsillectomy. Positive airway pressure can lead to resolution of associated aneurysms. Okay, yes. Medical condition of anuresis: if constipation infrequent or hard stool, and encorporiasis, there is with or without palpable stool mass. If it is bladder dysfunction, daytime this incontinence, weak stream, urgency, straining, with or without recurrent UTI. UTI, if it is UTI positive urine culture, there may be UTI symptoms. If it is CKD, again daytime incontinence, but there is weight loss and fatigue, and hypertension, proteinuria, hematuria like CKD features. So bladder dysfunction has daytime incontinence and CKD has daytime incontinence. Polyuria, polydipsia, polyphagia for diabetes and weight loss and fatigue. And in diabetes there is glucosuria, and in diabetes insipidus there is polyuria, polydipsia and low urine specific gravity. And in OSA, obstructive sleep apnea, there is snoring, hyperactivity, inattention, and adenosine hypertrophy. Okay. Okay.